Hello and welcome back. So today this will be the third part of our discussion on cardiac physical examination, and this is obviously the sixth video on our approach to chronic dyspnea. So I'll be discussing the following headings today. I'll be talking about added sounds, and then I'll be discussing some miscellaneous points. Now, in added sounds, we have systolic added sounds and we have diastolic added sounds. So this will generally be the theme when we come to murmurs at a later date. We'll also be first classifying them based on systole and diastole, because the pressure gradients that result in the hemodynamic abnormalities that then result in these abnormal sounds, murmurs or added sounds, uh, happen. Obviously, the pressure gradients change in different chambers during systole and diastole. So these two things make a big difference to what kind of sound, where, etc. So that's how we're going to approach it. Okay. So if you're going to start talking about systolic added sounds, what I'm going to do is I'm going to shade out the diastolic components of the cardiac cycle. So essentially, we are left with the systolic component, that is this. Okay. Now, in the systolic component, as you can see, there's increased pressure within the left ventricle, which increases from the diastolic blood pressure and goes right up to the systolic blood pressure and then comes back down. Okay. So, any added sound would be powered. The energy that is converted into the sound would come from this pressure gradient. Okay. So, what kind of sounds can you get? The first thing that you can get is what we call a systolic ejection click. Okay, so this happens when a normal pliable aortic valve suddenly opens up, and because it suddenly opens up and there's a pressure gradient, and because of that, what ends up happening is the valve leaflets being pliable suddenly tense up, and that produces a mechanical wave which results in an ejection click. This can get amplified if the root of the aorta is particularly dilated. Okay, so it is better heard in that situation. The other sound that you can get is you can have a sound arising when there is a prolapse of the mitral leaflet. Okay, so this sound is then what is called a non-ejection click, because it is also a clicking sound, and it is obviously from not the ejection of blood into the aorta. So this is called a non-ejection click. Okay, so the interesting thing about the non-ejection click versus the ejection click is that it has a very interesting, almost counterintuitive relationship to diastolic LV and diastolic volume. So what happens is, in patients who have mitral valve prolapse, so this is your left ventricle. Okay, their ventricular, no, the normal mitral leaflets are of this nature. Their leaflets are patulous, so they have a lot of myxomatous degeneration of the soft tissue within the body of the leaflet. So as a result, the leaflet is almost folded up, looks like a curtain. So what ends up happening is that if your LV end diastolic volume is increased, then the ventricle dilates. So when the ventricle dilates, the essentially the leaflets get ironed out. Okay, they get spread out. So the leaflets start looking much more, much flatter. Whereas if the reverse happens, that is the LV end diastolic volume is decreased, then the leaflets are even more crumpled up and more folded up. Now the issue is that, see, during systole, the LV pressure increases, and the force applied per unit area is what is pressure. So this pressure is applying a force on the leaflet. Now, because there are certain creases, no, the force applied on the entire area of the leaflet is not uniform. Those parts of the leaflet that are crumpled up, okay, those get a greater force, and those that are not get a lesser force. Okay, so what can end up happening is that the leaflet in certain areas gets tented up. So the leaflet during systole gets tented up like this. Okay, and this might also get tented up. So once the leaflet is tented up, it is no longer abutting, the leaflets are not abutting each other, so there is a regurgitant jet. Okay, now this tenting up of the leaflet produces a clicking sound, a musically pure sound, because one single component of the mechanical component, that is the leaflet, is vibrating at a certain small narrow range of frequencies, and after that it is succeeded by a systolic murmur. Okay, and this is obviously a murmur of chronic mitral regurgitation. We'll come to that when we discuss murmurs. So this would be a systolic murmur that would be preceded by a non-ejection click. Okay, so unlike the ejection click, which increases with increased diastolic volume, this is a sound that occurs earlier if the diastolic volume is decreased and occurs later if the diastolic volume, the LV and diastolic volume is increased. Okay, so it is a little bit different from other heart sounds. Okay, similarly, we'll come to the ejection systolic murmur of hypertrophic obstructive cardiomyopathy, and for different reasons, it follows a very similar pattern. Okay, it is inversely related to the LV and diastolic one. So this is what happens. This becomes very patchless. Okay, because it is patchless, if there is a decrease in the LV and diastolic volume, the leaflets tend to tent up earlier. When they tent up earlier, there is a regurgitant jet. There's a non-ejection click followed by a regurgitant jet. Okay, so what we end up having is that the mitral valve leaflets are more crumpled if the LV and diastolic volume is low, and so the non-ejection click occurs earlier. Okay. Now, just to summarize, these are the two systolic added sounds. We have our ejection click and we have a non-ejection click. Okay, the ejection click happens because of sudden cessation of a pliable aortic valve or pulmonic valve while it is opening. Okay, and that produces a relatively musically pure sound. Technically the timbre is good, is what we say. So this happens if the patient has got a valvular aortic or pulmonary stenosis. But see, importantly, the valve leaflet should not be tethered and should not be damaged too much. Okay, they should be still pliable. Okay, it's just that the lumen of the aortic or pulmonary or artery base should be narrowed. Okay, the other thing that can happen is you can have a root dilation of the aorta or the pulmonary artery, and that then amplifies this sound. Okay, and that ends up producing a more audible click. Okay, it has also been described in bicuspid aortic valves, and when the patient has systemic hypertension. Okay, with a primarily because in systemic hypertension the aortic root tends to dilate over a period of time. Okay, so that is why it has been described. But mechanically speaking, factually, it is a pliable stenotic semilunar valve, that is this thing, either the aortic valve or the pulmonary valve, or there is a dilatation of the aortic and pulmonary roots. Okay, now obviously this is an ejection sound. Okay, so since it is an ejection sound, it corresponds with opening up of the leaflets. Now see, S1 corresponds to AV closure, the closure of the mitral valve. Okay, so this is the closure of the mitral valve. Now, after closure, there will be isovolumic contraction, after which the aortic valve opens. So here the aortic valve is opening up. So this space in between, this time, is actually the isovolumic contraction. Okay, and as we've discussed, usually the pitch of a sound is directly proportional to the pressure gradient that is produced, resulting in the hemodynamic abnormality, because the pressure gradient is the work done on the fluid column, and that is what is being converted into kinetic energy. Okay, so more the kinetic energy, more will be the energy of sound. Okay, so that tends to have a higher component of that sound than in a high pitched within the at higher frequencies, because there is more turbulence. Okay, fine. Now the non-ejection click, like I've said, has an inverse relationship with the LV end diastolic volume. So it can start in early diastole and it can start in late diastole. Okay, so that is why I've shown this diagram. The curve shows that it could be early or late. So it would be early if there is a decrease in the LV end diastolic volume. Okay, and it would be late if there is a increase in the LV end diastolic volume. Why I have explained in the previous slide. So these are the two systolic added sounds. Now coming to the diastolic added sounds. Like I did earlier, I'm going to shade out the systolic parts of the entire this thing, entire cardiac cycle, and I will shade out the isovolumetric relaxation period. Okay, so the what we are left with essentially is the diastolic period. Okay, so the diastole also includes isovolumetric relaxation, but this is diastole without isovolumetric relaxation. Okay, so here the pressure gradient is from the left atrium to the left ventricle. Now, importantly, during the early rapid filling phase, and I had the risk of repeating myself too many times, again I'm telling you, it is the negative pressure within the left ventricle because of its relaxation during early diastole, that is what is creating the pressure gradient. Okay, so the pressure here is negative, that is why I have color coded it as yellow. Okay, and late in diastole, it is atrial contraction that is creating a pressure gradient because of positive pressure between the left within the left atrium. Okay, so what are the sounds that we can get? So the first sound that we get is due to the early rapid filling. Okay, so sorry. So the first sound that we get is due to during early rapid filling, sudden tensing up of the atrioventricular valve, that is the mitral valve in this case, and that is what we call an opening snap. Now see, normally the flow rates across the mitral valve are very low. Okay, so they don't typically cause this sudden rapid tensing up of the valve. Okay, this happens only when there is increased flow rate across the valve. So the presence of an opening snap means the flow rate is increased. Okay, so we'll see how that becomes relevant. So classically, you would have heard it in the context of mitral stenosis. Now see, in stenosis what ends up happening is in order to maintain the LV end diastolic volume, okay, in order to prevent a reduction in the stroke volume and therefore the cardiac output, the left atrial pressure has to increase. Okay, so the gradient between the two is increased, and typically, at least initially, there is an increase in the flow rate across the valve. Okay, so flow rate per area. So as we've already discussed previously, the area times volume, the velocity is a constant for a non-compressible ideal fluid. Okay, so because of that, since the area is decreased, the flow rates will increase. The velocity will increase, and therefore the flow rate will increase. Okay, so that is your opening snap. The second sound that you can get is what we call the pericardial knock. Now, pericardial knock is actually just an exaggerated S3. Okay, happening in a patient who's got a constrictive pathology within the ventricle. So the ventricular compliance is decreased, and as we discussed in case of RV fibrosis, chronic constrictive pericarditis, endomyocardial fibrosis, in all of those situations, it is the early relaxation of the ventricle that is prevented. Okay, so it relaxes, yes, okay, but there's an upper limit, and beyond that it doesn't relax. There's a tensile limit. Okay, so because of that, when that limit is suddenly reached, the ventricle suddenly tense up, and at that point a sound is created, and that is essentially an S3 only, but this is an S3 that has slightly different character and is a little bit different sounding and slightly earlier than normal S3. So that is what we call a pericardial knock. Okay, and the last sound that we can get is what we call a tumor plop. Okay, so a tumor plop happens because of a tumor or classically an atrial myxoma that is present within the left atrium. Okay, so what happens is this tumor is a pedunculated tumor. Okay, that essentially is moving freely within the left atrium. So when blood is moving from the left atrium to the left ventricle at any point, depending on the positioning of the patient, the tumor can go into the lumen can enter the AV valve lumen or the AV valve orifice and block it. Okay, so when it blocks it, that produces a sound. Okay, it suddenly closes off the lumen and that produces a sound. Okay, and that sound is called a tumor plop, and essentially depending on the patient's position, when it happens or whether it happens or not, okay, will change. So it's a positional change, and it can happen during early diastole. Usually it happens during mid to late diastole. Okay, so that is your last sound, that is your tumor plop. Okay, so just summarizing, again there are three sounds. There is the opening snap, and like I said, it is due to, again, just like a rejection click. Okay, it is due to sudden cessation of an opening AV valve, typically the mitral valve. Now this happens because of increased flow. So classically described with mitral and tricuspid stenosis, but it also happens if there is increased flow across the mitral valve due to other reasons. So it can happen in any case with increased cardiac output. Okay, so in that situation it would occur with S3, whereas in mitral stenosis you can never have enough early ventricular filling to produce an S3, and that's how we actually differentiate between a functional MS and a actual true mitral stenosis. Okay, we'll come to that in our discussion on murmurs. And the other thing is, because it is due to tensing up, no, it is a high pitch sound, so it is a diastolic high pitch sound. Okay, usually systolic sounds are high pitched, but diastolic sounds, because the pressure gradients are never that high, are typically not high pitched. So this is importantly a diastolic high pitched sound. Okay, like we discussed in a previous video, this is a little bit of a odd thing. So because it is odd, it is something that is routinely it is something that is asked. Okay, then see what else could cause increased flow rate across the mitral valve. So if you have the atria and then you have the ventricles, okay, you have your ventricles, say this is the left ventricle, this is the right ventricle, okay, and there happens to be an atrial septal defect. Okay, now when there is an atrial septal defect, if there is if there is, say, there is some kind of increase in pressure within the right atrium, the right ventricle, say there is, or there is an obstruction to flow, there is complete tricuspid atresia, okay, or there is increased RV pressures, okay, that is PAH has developed, then there will be a right to left shunt. This is the right atrium, this is the left atrium, so this is a right to left shunt. That would increase the amount of blood that is going across the mitral valve, because there is blood coming from the pulmonary veins, and now there is this extra blood that is falling. That causes it produces a opening snap. Okay, similarly, if you have, say, a mitral regurgitation murmur, so the leaflet here is, the leaflets don't close properly, so there is during systole there is a increased amount of blood going back into the left atrium. That blood will obviously come back. Okay, so when that blood comes back, what will happen is that there will be increased LV and early diastolic filling. Okay, so that's why it is also a cause of an increased V wave with rapid wide descent, if you remember from our JVP talk. So a mitral regurgitation murmur would also be a cause. Now the third thing that can cause it is, you can have an opening snap when you have left to right shunting, but left to right shunting before the level of your outlet. Okay, so either you have a ventricular septal defect, which results in increased blood going into the right ventricle and then going back into the pulmonary circulation and then coming obviously back to the left atrium. So there is increased pulmonary flow. So okay, anything that causes this kind of increased pulmonary flow would increase the amount of blood entering into the left atrium and therefore entering into the left ventricle. Okay, so increasing the flow rates across the mitral valve. So these are the causes of opening snap. Again, an opening snap is almost, considered, it is not definitely pathognomic, but it is almost, synonymous with a mitral stenosis. It is definitely not. Okay, so these are the causes. It implies increased flow rate across the mitral valve orifice, and that is the only thing that you must conceptually keep in your mind. Okay, from there you can deduce the causes later. Okay, now the next sound that we talked about is obviously our pericardial knock. So in case of a pericardial knock, like I said, it is just a S3. Okay, so there is rapid early diastolic filling in a non-compliant ventricle. Okay, so this happens obviously with fibrosis of the right, either the pericardium of the right ventricle or the ventricles, or because of LV fibrosis, RV fibrosis, or it happens with endomyocardial fibrosis. Okay, but classically it has been described with chronic constrictive pericarditis. Okay, now the last sound is the tumor plop, and as we've discussed, it changes with position. Okay, and this happens when the myxoma hits the leaflets of the valve. Okay, again it will be low this thing, but the tumor plop, it changes position. It changes position based on the position of the patient. When it occurs in diastole, it changes based on the position of the patient. Now we're going to talk about some things that are related to our talk earlier on the S1 through S4 sounds. Okay, But these are things that I would ask from a person who is a resident who is quite advanced in their understanding of cardiac heart sounds. So I would strongly suggest that you go back to our discussion on the S1 through S4 sounds, because like you can see in this picture here, see, this is Kuldeep Yadav bowling left arm leg spin. So the ball should be turning in this direction. Okay. So this is Kuldeep Yadav bowling left arm leg spin. So the ball should be technically turning in this direction. Okay, but it has actually turned across the batsman and hit the off stump. Okay, so this is what we call a googly, and this is a left-hander's googly. So that is why I've shown it here. Now, why I'm telling you this is because sometimes things that you take for granted, that is a leg spinner turning the ball towards towards this side, a left arm leg spinner, sometimes things happen in the opposite direction. Okay, so this is what we're going to discuss, and so we need to know first what is the normal. So please go back and review that, and then come back, and you can this is quite fun, so you can have a good time looking at these and trying to understand this. Okay, it's intellectually quite interesting. So the first thing is, we'll start with the simplest, that is a variable loudness of S1. So like I told you, the loudness of S1 essentially varies based on diastolic duration. Okay, so if the duration of diastole varies between cardiac cycles, if the diastole is short, S1 will be loud. If the diastole is long, S1 will be short. S1 will be soft. Okay, so if you have, say, tachycardia, okay, but irregularly irregular tachycardia, you will end up having variable S1. Okay, but the patient will be having a heart rate that is high. Okay, there are other causes of irregular tachycardia also, namely an atrial flutter with a variable block, in atrial fibrillation with variable block, polymorphic ventricular tachycardia. Okay, and also a patient who's got sinus rhythm but has got multiple atrial premature complexes, supraventricular premature complexes. We'll come to that in our discussions on tachycardias. But the representative tachycardia of this sort is atrial fibrillation, and that causes a variable S1 loudness. Okay. Now, if on the other hand the patient has got a bradyarrhythmia, in that situation, anything, now if you remember, I have mentioned that first degree heart block increases the duration of diastole because it delays the conduction from atria to ventricle. So as a result, ventricular diastole is longer. So because of that, it causes a soft heart sound. Okay, but I also said that second degree heart block can cause it, but it doesn't cause persistently soft heart sounds. What it causes is a progressive increase. If it's a second degree Mobitz type 1 block, we'll discuss this in bradyarrhythmias, there will be a progressive increase in the PR interval. Okay, so because of that, progressively the S1 sound will become softer till the time the beat is missed. Okay, then again it will become loud, then softer till the time a beat is missed. Similarly, with your second degree Mobitz type 2 blocks, there will be soft S1 because there is a block. Okay, usually the PR is slightly long. Okay, but it will be randomly missed. There will be missed beats in between. Okay, and with a complete heart block, the atria and the ventricle are contracting, out of sync with each other. So because of that, the duration of ventricular diastole will vary wildly. Okay. Depending on how fast the atrium is moving, what the frequency of atrial contraction and the frequency of ventricular contraction, there may be a pattern. Okay, but this is something that requires a little bit of thought. So maybe you can sit and think about it yourself. Okay, so that will have a pattern, but that pattern will change over a certain time period, and we'll discuss that more when we discuss bradyarrhythmias. Okay, now coming to splitting of S1. So I have emphasized and loudly proclaimed that it is only the loudness of S1 that is significant, but I did mention that S1 can be split, if you remember, in our talk on the splitting of S2. Okay, so when was that? That was in the context of a right bundle branch block. Okay, so normally S1 is not split because whether there is inspiration or expiration, the gap between the mitral component and the tricuspid component is less than 40 milliseconds, so it's not audible. Okay, now to normal human ear, actually normal human auditory cortex. Okay, so but if you have a right bundle branch block, there will be a split because the tricuspid component will definitely get delayed. Okay, that is something that is going to happen. Okay, so that having been said, that would be a truly split S1. Okay, but say there is a late, see S1 is due to closure of the AV valve, that is the mitral valve. Okay, so what if there is a sound late in diastole, just before the AV valve closure, or there is a sound early in systole, okay, but in the same area. Okay, so those sounds would pretend to be part of the S1 sound. Okay, so there would be a pseudo split. Okay, so these two sounds, say there is S1 followed by a early non-ejection click. Okay, or there is S1 preceded by a S4 sound. Okay, now both S4 and non-ejection click are best heard at the apex, just like the S1 sound. Okay, so in that situation, both of them would give the appearance that there is splitting, but it is actually pseudo splitting. Okay, so this is called pseudo splitting of S. Okay, now so how would you differentiate it? So one thing is the non-ejection click, if you recall, is a soft pitch sound. So normally when the S1 is split, the components are mitral and tricuspid, both are high pitch sounds. Okay, so because the pressure gradient between both sides is quite high, even on the right side the pressure gradient is not that high. It will be, in a normal person without pulmonary hypertension, will not be that high. So basically you may have a second part of the sound that is high pitched. Okay, that is however not a reliable way to differentiate it. The second thing that you can say is that the non-ejection click has a clicking sound. So that is one subjective way to differentiate it. Okay, and the other thing that we've discussed is that, see, if you decrease the end diastolic volume, okay, the non-ejection click occurs earlier. So if you ask the patient to stand up, okay, the venous return to the heart will decrease. So when the venous return to the heart decreases, the end diastolic volume will decrease. So the non-ejection click will occur a little earlier. Previously, it was occurring during early diastole already. Okay, that is why it was causing confusion. Now it will become so early that it will start overlapping with S1. So you won't hear it as clear. Okay, so once the patient stands up, if it is actually a pseudo split S1, then it will completely disappear or it will become less prominent. Okay, and obviously we know non-ejection clicks are followed by a mitral regurgitation murmur. Okay, so a split S1 would not be associated with that because it is associated with RBP. Those would be two completely different things. Okay. On the other hand, if you have an S4 sound preceding an S1, see, if S1 is split, the first sound is what is high pitched. Okay, the mitral closure sound. Now the first sound here is actually the atrial contraction sound. So that has to be low pitched. So the first component will be low pitched. So I hope that is clear. It is a little confusing and it requires you to understand both the S1 sounds and the splitting of S2 and the concept of splitting. So please go back to that if you find it difficult to understand. Okay. Now the last topic I'll be talking about is what we call pseudo splitting of S2. Okay. So why do I call it pseudo splitting? Because there is no true splitting, but you hear it as splitting. So what was splitting? Splitting can be of two types. It can be wide splitting or it could be paradoxical splitting. Wide splitting would mean that during inspiration and expiration, you've got splitting rather than the normal that is just during inspiration. And paradoxical splitting would mean that there is splitting audible during expiration but not during inspiration. Okay, I hope that much is clear. So it's pseudo splitting. So there is no true splitting happening here. So probably what is happening is there is something pretending to be one component of the S2 sound. Okay, so S2 corresponds to what? It corresponds to the closure of the AV valve. Okay, so what are the sounds, added sounds that can happen before or after close the S2 sound? You could have an early diastolic sound that is right after closure of the aortic valve, because the aortic valve closes at the beginning of isovolumetric relaxation. Okay, which is the first part of diastole. So what are the diastolic sounds? We already discussed them. That is our opening snap, okay, our pericardial knock, our tumor plop, and obviously S3 is also corresponds to early diastolic filling. So that is an early diastolic sound. So these would all mimic the P2 component of S2, okay, and would be audible during inspiration and expiration, but this is not true splitting. Okay, so then how do you differentiate it? So one thing is that obviously splitting is heard in the pulmonary area. Okay, so if it is pseudo splitting, the pulmonary component would actually not be would be the opening snap, and the opening snap is not best heard in the pulmonary area. It is heard best in the apex. So the first thing is see whether it is in the apex or not. Okay, now the other thing is that the opening snap has a clicking quality. Okay, the that subjective quality is not there with the P2 component. Okay. Okay. So what about S3? You will differentiate S3 in the fact that S3 is actually a low pitch sound. Okay, whereas the P2 component, again, because there is a pressure gradient between the pulmonary component and the pulmonary artery and the left right atrium, will be a high pitch sound. Okay, that exceeds 40 millimeters of mercury. Now, what about the pericardial knock? So, pericardial knock is just an S3, but it occurs in a patient with chronic constrictive pericarditis. So, there will be other features of chronic constrictive pericarditis rather than the normal causes of S3, that is high output cardiac states. Okay, and tumor plop, like I've already discussed, would show postural variation. Okay, so please think through this. It will become quite obvious. Now, what is a paradoxical pseudosplit? So you get a paradoxical pseudosplit when you have a P2 component is there, okay, but it is not audible during inspiration. So during inspiration, normal splitting is occurring. Okay, A2 is occurring, then P2 is occurring, but for some reason, the P2 component of this during inspiration is not audible. Why does this happen? This happens because during inspiration there is more air in the lungs. Okay, so there is more air that is there between the point where the P2 component is being produced and where your steth is there. Okay, so in that situation you can have air tissue interfaces, and that causes a lot of that sound to get reflected back. Okay, so it doesn't reach your steth, and because it doesn't reach your steth, you don't hear P2. So what you hear is during inspiration there is a single sound. Okay, and then you can fool yourself into thinking that during expiration there is a double sound. So this is not real paradoxical pseudosplitting, but yet see, this can give you the impression of pseudosplitting in some situations, particularly if the patient has already got a wide split S2. Okay, because then even in expiration there will be a split. Okay, fine. The next thing is you can have this can happen in what we call when your constrictive pericarditis. Okay, so this happens because in constrictive pericarditis the pressures within the right ventricle increase the RV end diastolic volume increases a lot during the latter half of inspiration. So because of that, your P2 component becomes less audible. Okay, so I hope you understood that. So these are the two situations in which you end up having paradoxical pseudosplit. Okay, so that brings us to neatly to the end of our discussion on added sounds, and then some variations in those in the S1 through S4 sounds because of those added sounds. Okay, the last part of the video is quite advanced, and I would suggest either you give it some time, try to understand the S1 through S4 and added sounds first, and then come to the last part of the video. Even if you don't necessarily understand it right off the bat, you can give it some time and understand it later, but it is something very interesting. Okay, these last three scenarios, so I would suggest that you try to understand it. Okay, so okay, thank you, and I'll see you in the next videos. In the subsequent three videos we'll be going into the mechanisms behind the physical mechanisms behind the different ways we assess ventricular function and pulmonary hemodynamics in echocardiography, because it is a basic investigation that requires interpretation often, even on the first opus dei visit or on the first or second day or post admission in wards. So essentially, like the PFT, it becomes like a routine investigation. Okay, often the patients come with an echo report. Okay, so you may not even have to order an echo, but you may have to interpret it. So we'll be discussing those, and then we'll go into each individual scenarios with our 4 clinical scenarios that can result from this initial presentation. Okay, So thank you for listening, and I'll see you in the next video.